very, very graciously interwoven case vignettes to really stimulate a lively discussion on this topic. So just a couple Zoom reminders. Please rename yourself with your first and last name in your clinic. If you're not speaking, please mute your microphone. We'd love to see your face if you're able to be on camera. We understand, of course, if you're in transit or you can't be on camera for whatever reason. And if there's a number of you in the room, then please enter all of your names in the chat so we can track for attendance. So for University of Washington faculty, staff, or students, please complete the mobile text registration and sign in. If you haven't yet registered, you can send your University of Washington email address to the number here, 833-394-7078, and you'll receive a response stating that your number has been updated. And then, pardon me, to track that, you'll receive a response, and then you can text 13461 after registration to receive the CME credit. But don't worry, for all other attendees, your attendance is recorded by the program manager and Zoom Analytics. So please make sure that we can see your full name, and Sarah McKitty can reach out to you in the chat if she needs additional information. These sessions are recorded and they're CME for everyone. It's 1.25 credits through the University of Washington. None of the planners or the speakers have any relevant disclosures. And if there is ever anything to disclose, we take we take any pathway to sort of make sure that we are disclosing any relevant financial information, none of which need to be disclosed today, however. Okay. There's a number of additional project echoes through the University of Washington, including geriatrics, behavioral health and traumatic brain injury, psychiatry and addiction, and telebehavioral health training series, as well as an amazing telephone consultation line for people with with complex pain medications, particularly high-dose opioids, as well as a telepain CME accredited case conference series for pain management support for Washington State healthcare providers. Additionally, there are Grand Rounds archives both in neurology and psychiatry, as you see here. And please do consider bringing your case presentations forward. You're a vital part of this community, and no case is too simple. We can all learn together by bringing these cases forward. Please reach out to Sarah McKitty if you have cases to present. Just a couple last reminders. We protect PHI, so during the sessions, please don't display or say anything that could reveal patient or family members. Remember, all sessions are recorded and available on the website. And please do complete the post-session survey. It's like 1 minute, and it helps us to improve these sessions and make them, increase their value for the community. So please do take the time to complete the session. Here's our hub team, and as you see, through the Dementia Action Collaborative, we represent a number of health systems across the state of Washington, as well as a number of disciplines and perspectives. And we've provided over 2,300 instructional hours since the inception in June of 2020. In 2024, 100% of respondents reported that Project Echo Dementia improved their quality of care for patients with dementia, and nearly 64% reported changes by others within their organization based on their participation in Echo. We're serving 96 sites. Please do, if you see this, if you find value in this, share with your colleagues as we continue to grow to scale dementia-capable care in the state of Washington. So without further ado, we're very fortunate to have Dr. Tom Grabowski, who's going to speak first, and then Dr. Barak Gaster. And Dr. Grabowski is the medical director of the University of Washington Memory and Brain Wellness Center and the director of the UW ADRC. And he'll speak first, and then I'll introduce Barak, who is a hub member and who's well known to the community as well. So thanks, Tom. Please take it away. I'll stop my share.
All right, well, good afternoon, everyone. I hope you can see the slides. My name is Tom Grabowski. I'm a neurologist, even though I have appointments in radiology and neurology, just to clarify that. And it's a pleasure to talk to you today about blood biomarkers in Alzheimer's disease in current practice. And I don't have anything that's specifically relevant to the material I'm presenting that I'll need to disclose. I do receive NIH funding for maintaining the Research Resource Center at UW. And what I hope to do is lay a conceptual basis for understanding what blood biomarker testing is and can't tell us. I want to emphasize the importance of establishing the setting in which blood biomarkers are used, uh, their utility, their limitations, and then go over the current practice recommendations that were published in 2025 for use of AD blood markers in clinical practice. So just to level set with everybody, the first thing is, and I start this way all the time. There's two levels of diagnosis we talk about. What's wrong with thinking and memory, sort of cognitive level of diagnosis, and then what biologically is the matter to explain that trouble with memory and thinking. And on the cognitive level, things move in a continuum among those who have a complaint, from normal or subjective concerns uh, and to be worried about your memory is normal as you age, obviously. But when there is an objective level of impairment, we start to use the term mild cognitive impairment, meaning someone has measurable memory or cognitive decline, but they're essentially an independent individual. It's dependency on others that leads us to start using the term dementia. And it seems simple, but if you keep it straight, cognitive and causal diagnosis, you really avoid a world of hurt in this field. And what I would like to emphasize today is it's very important to think about the cognitive diagnosis before you think about blood biomarkers. So here's a case vignette, a 76-year-old woman who complained her short-term memory is not great. She's a retired attorney. Has been having trouble remembering directions. She's had trouble remembering whether she talked to a given individual that day or not. And her daughter confirms that, yeah, for 2 or 3 years, every time we talk, she says something that she's already told me. She has some vascular risk factors, and her MoCA score is in the nominally normal range when I first see her, 28/30, a normal exam. We follow her initially with subjective cognitive concerns, but she develops a lower MoCA score over the ensuing 2 years. And her MRI scan at upper right shows some subtle, for age, some subtle atrophy, and maybe that radiologically left hippocampus there is a little small. But this pretty much outlines a case of amnestic mild cognitive impairment, otherwise uncomplicated. And just to now step back for a second and talk about causal diagnosis, or what's wrong with the brain if you could look at it under the microscope to explain mild cognitive impairment or broader cognitive loss. And one of the things you might, of course, see is Alzheimer's disease, which is defined by these two hallmark lesions, the amyloid plaque or neuritic plaque and the neurofibrillary tangle. So that the neuritic plaque is, got a core of amyloid beta protein with a surround of activated microglia, which are the brain's inflammatory cells, and these neural processes which are dying back, sort of like the Wicked Witch of the West kind of feet dying back from the plaque. And then intracellularly, you see these accumulations of a different protein called tau protein, which are hyperphosphorylated and marking the dysfunctional and eventually dying neurons. That's what that microscopic picture defines Alzheimer's disease. And the amyloid plaques and the tau tangles have another level of significance for us today, though, because they're each composed of a characteristic abnormally folded or phosphorylated protein that we can detect and measure with either imaging or biofluid tests. And in that sense, they provide the basis for biomarkers of Alzheimer's disease, biological markers of Alzheimer's disease. And I think maybe to understand the blood markers, it makes sense to go back to the 1990s when the amyloid PET scan was invented. So this was a revolutionary test at the time, where radioligands could be deployed and would home in on amyloid protein in the brain, and for the first time demonstrate a pathological load care, pathognomonic for Alzheimer's disease in a living individual. And what I have on the screen is a normal or negative amyloid PET scan. Here's the MRI scan at lower left. And the tracer is giving the dark appearance on this upper panel. And you can kind of make out that the white matter skeleton of the brain is being non-specifically bound by the tracer. And so when you can see this gray-white matter distinction clearly throughout the brain, that's a negative visual read on an amyloid PET scan. And in contrast, here's what a positive amyloid PET scan looks like. You lose all that distinction between gray and white matter, get this ground glass sort of appearance. And this usually isn't a close call. In someone with mild cognitive impairment, if they have Alzheimer's disease, this test is usually floridly positive, maximally abnormal right from the outset. And you get either a visual read like I just talked about, or a quantitative read where you actually use something called a standardized uptake value ratio, but increasingly we use this universal scale called Centiloid scale, which can put all amyloid PET scans on a common scale, and you can define a normal amyloid burden or an abnormal burden. So that was a revolutionary development. It's not something which is obviously scalable or universally accessible to people, but we'll come back to the notion that the blood biomarkers are being held to the standard of these of how well they predict the result on this test, okay, and sort of inherit all of the interpretation that loads on an amyloid PET scan. So if you have a positive scan, we know from correlation with autopsy that there's a moderate density of plaques present. You can say Alzheimer's pathophysiology is present. And at the moment, I would say this is the gold standard for in vivo diagnosis of Alzheimer's disease. And now, if you look at data that records the frequency of a positive amyloid scan in the population, that's the blue curve here. And the red curve is the frequency of Alzheimer's disease dementia diagnosis in the general population. And you can see the parallel curves that are separated by about 15 years. And at age 70, you can read out maybe 20-25% of individuals in the population will have a positive amyloid scan. So the take-home point here is a positive scan is not uncommon, and a positive scan is also not identifying only symptomatic individuals. It's turning positive 10, 15, maybe fully 15 years before people have dementia. And I'd say, you're sort of getting more of you're not only getting the dementia and mild cognitively impaired group, but you're getting the rest of the iceberg too, the pre-symptomatic cases as well. And so one problem with an amyloid PET scan is you don't know necessarily where you are in the course of disease. You may have a positive scan because you're in the preclinical group, destined perhaps someday to develop symptoms, or it may be because you are a symptomatic individual currently. Now turning to blood markers, there's a lot of markers which have been advanced. Cerebral spinal fluid markers have been around for quite a few years, and they depend on detecting amyloid species. Code for amyloid beta 42 and amyloid beta 40, where 42 is the thing that is really the core of a neuritic plaque. And so it's about detecting 42 or 42 in ratio to 40, the unaffected species. And the other thing is varieties of phosphorylated tau, and the tau molecule is really complicated, but you're hearing these days about 181 phosphotau and 217 phosphotau. So in spinal fluid, there are some of these which are tests which are FDA approved, and they're approved because they're 90% accurate in predicting the outcome of an amyloid PET scan. And why we're here today is because now the blood plasma markers are available, obviously vastly more accessible and I would dare say acceptable to patients and ordering physicians. And those at the lower left are the same species of amyloid and tau. And some of these are beginning to be shown to be 90% predictive of an outcome on an amyloid PET scan. Okay, so the standard which the FDA is holding these tests to is, are they 90% accurate in predicting what you would have on an amyloid PET? And currently, you've probably heard in the news, this test, 217 phospho-tau over amyloid beta 42 ratio, that test marketed by on the Lumipulse platform has recently, last May, been FDA approved because it passes this test. But there are others where the literature has clearly shown a 90% accuracy rate, and those are coming. So there's several tests which will be available, several more tests which will be available in the near future. So the idea is to take the amyloid PET scan out of the loop, and can you depend on these blood markers as an in vivo diagnostic standard for Alzheimer's disease? So back to case one, my patient with amnestic mild cognitive impairment has a plasma 217 p-tau test. Her value is elevated. You'll notice that this is a send out test to Mayo Clinic, and it's just looking at 217 p-tau. You see it's reported back with 3 tiers of results with essentially two cut points, and this falls in the very clearly positive range for that test, and which has been shown to be 90% accurate with respect to PET scan. So this supports the presence of the Alzheimer's pathophysiology and a diagnosis of amnestic MCI due to underlying Alzheimer's disease. And 2 years into her course, as lecanemab becomes available, this patient turns out to qualify for anti-amyloid therapy. So this is like the straightforward specialty clinic use case for an Alzheimer marker currently. The advantages of biomarkers are should be pretty clear. They give a basis for early diagnosis. For anti-amyloid therapy, we love to have people with a mild cognitive impairment early in the course, as early in the course as possible. We think that they're more effective in that situation. They allow you to align treatment and mechanism, so we can make sure we're giving anti-amyloid therapy to someone with amyloidosis, if you will. And they also help in clarifying atypical case presentations, like a non-amnestic presentation of Alzheimer's disease. Those are the sorts of things you use diagnostic biomarkers for. And these blood tests are basically diagnostic markers. Yes or no, is that biological feature present? Another kind of biomarker is a progression marker. That's something you could use to track progression or evaluate the effective treatment. And I'm mentioning that only to say that that's not what these blood biomarkers can do right now. They're qualitative tests that say yes or no. So let's look at another case. Another 76-year-old gentleman. He's got trouble sleeping. He's forgetting why he finds himself going on errands, wondering, what did I come for? His mother had dementia. He's got a lot of vascular risk factors. He has some chronic renal insufficiency. He presents worried about his family history and thinking, maybe I have this too. And the physician orders a 217 p-tau test, which is abnormally high, but falls in that intermediate range. And we have now a problem here for several reasons, because we don't know whether this person is objectively impaired or not. And we have a result which is indeterminate. Okay, so let's talk for a little bit about the limitations of these blood tests. First, I mentioned they turn positive years before impairment happens. So in those preclinical years, we don't have any effective, demonstrated effective pharmacologic intervention for sure. And you could say that these um, in the preclinical, in the asymptomatic or unimpaired individual, we really don't know whether there's any clinical utility to knowing this information. So it's not actionable. Secondly, the accuracy of these blood biomarkers has really been assessed in the specialty setting, really not in primary care. So there's a knowledge gap there. They're not able to estimate disease burden or track progression. And so far, we haven't talked about this, but multimorbidity where there would be, or comorbidity where there would be Alzheimer's disease pathologic change accompanying small vessel disease or Lewy body pathology, or maybe all three are present, and maybe there's some additional um, proteinopathy present. All of that is not illuminated with a blood biomarker. These are really very specific. Is Alzheimer process there? And the judgment that it's contributing or causal depends on lots of things. Okay, so there's nuance to the interpretation of a positive marker. And then finally, should be aware that elevation of the markers, the tau markers for one, uh, can occur in the setting of renal disease. So there's a reason to be cautious in this patient on that score as well. So I would say for this case, the cardinal thing is the plasma marker is really not appropriate in the absence of documented cognitive impairment. Anyone with an intermediate result like that is probably going to need confirmatory testing. And if you followed me so far, at least in the specialty clinic, the route of appeal for a confirmatory test is an amyloid PET scan. And we find that we might need to do that about a third of the time. And then the other pragmatic point here is that in this patient, you have to think about his renal disease too. So when is a Alzheimer biomarker actionable? And I would say diagnostically when evaluating an atypical presentation, like a non-amnestic or presentation or a rapid progression. And therapeutically, when we're qualifying an AD patient for one of the new monoclonal treatments, but those are indicated for symptomatic individuals, mildly symptomatic individuals, so MCI or very mild dementia only. And if you're a researcher, that means, clinical dementia rating scale 0.5, but that's basically a person who is able to understand and give consent. And these treatments have some serious side effects, which go under the rubric ARIA, or sort of a small vessel vasculopathy that happens. And because of that risk, you want to make sure that you give them only to patients who have documented Alzheimer's disease. And in both cases that I mentioned there, the use of these tests is in the setting of a comprehensive diagnostic evaluation when there's already established cognitive impairment. And that brings me to the practice guideline, which that was published under the auspices of the Alzheimer's Association and rolled out at the Toronto meeting this summer. So there were two recommendations. First recommendation in patients with objective cognitive impairment. Sound familiar? Presenting for specialized memory care, you could use a high sensitivity blood biomarker test as a triaging test in the workup of Alzheimer's disease. So that would be a test that would probably fall short of the 90% overall accuracy rate, but it would be enough to, indict Alzheimer's disease, if you will, and justify follow-up with a confirmatory test like an amyloid scan. And second recommendation in patients with objective impairment presenting for care, if you had a high sensitivity and high specificity blood biomarker test. So one of these test set is exceeding 90% accuracy, and there are some coming that are heading more toward the 95% accuracy level. Then you could use it as a confirmatory test in diagnostic workup of AD. And I would say our first case today was somebody that I would put in that category. And then finally, they put out a good practice statement. So you should not obtain a blood biomarker test before a comprehensive evaluation by a healthcare professional, and test results should always be interpreted within clinical context. So I would say that this set of recommendations really is oriented away from primary care and is oriented to the use of blood biomarkers in a specialized setting. And I think that is, by and large, the appropriate stance to take at this point in time. So just to sum up, the blood plasma AD markers make AD testing a lot more accessible. That's their genius, but they're not really actionable on their own. They should be undertaken after establishing a complaint and cognitive impairment and as part of a comprehensive workup. And I like to think about it, they sort of inherit the benefits of an amyloid, the interpretive context of an amyloid PET scan, but they're a lot more accessible and straightforward to obtain. In the appropriate setting, the blood biomarkers can confirm diagnosis and candidacy for anti-amyloid therapy. And then just as a last statement, we really should expect a lot of evolution in this area of medicine. It's very dynamic. The way we evaluate people in the specialty setting has changed radically because of the availability of these over the last couple of years. And I think we're going to expect more changes in future. We were talking a little bit before starting today, what will happen if does turn out to be something that's effective in the preclinical epoch, which would, I think, require a rethink of this. But this is where things stand currently. And thank you for your attention.
Thank you so much, Tom. Fantastic. And I think this segues really nicely into Brock's presentation and to help us think about the appropriate setting. And as you emphasized, your guidelines and recommendations and current guidelines really are within specialty clinics and in the appropriate clinical context. So, Brock, I think as a primary care clinician, um, can talk about how he's grappling with this. And as we all know, Brock Gaster is developed cognition in primary care and has been a hub member since the beginning. So thanks, Brock. Take it away.
All right. So thanks so much for having me. And it is really such a humbling experience to be on a panel with Dr. Grabowski, who is such a nationally renowned expert in Alzheimer's disease. And so let me sort of dive in to give you the primary care perspective on blood-based biomarkers. And I also have no financial conflicts of interest to disclose. And really, so my goal today is to give a very, very practical case-based overview, how to think about these blood-based biomarkers. And I think as Tom has eloquently said, this is a very, very quickly changing field, and a lot of what I am about to tell you may be out of date in 18 months or 12 months or even 6 months, because there is so much active research going on in this field. So not to say that it will change, but it very well might change. And so really today, though, I think it's useful to have just a super practical set of cases that are geared for the non-specialist clinician in terms of sort of where are we right now in terms of how to think about blood-based biomarkers. And so, just to really kind of parrot a lot of what Tom said really, really well, which is just to sort of keep in mind the spectrum, the syndrome spectrum that happens as people move from changes that are consistent with normal aging to symptoms that are consistent with mild cognitive impairment to symptoms that are consistent with dementia, and how that is overlying the etiology of what could be causing that cognitive impairment. And as Tom said, and as shown here with the ovals overlapping, that it is very common for these etiologies to be happening together with one another. And so really, it is this really whole new world of the diagnosis of Alzheimer's disease that traditionally and still to some extent the diagnostic process for Alzheimer's disease is still a difficult determination to make. Like it is, relatively easy to diagnose mild cognitive impairment or dementia. And, that's the main focus of the work that I do. But once you get down into that next step of what is the cause of somebody's cognitive impairment, that's when things get kind of messy and fraught. And, even in the hands of the world's best experts that I would definitely consider Dr. Grabowski to be, that diagnosis is still uncertain, and you're often looking at this mixed picture. The majority of patients, especially those over age 80, really do have mixed forms of dementia where it's not just overlapping clinical features, but if you do autopsies of their brain, you see overlapping pathophysiology in their brain happening as well. But as Tom said, the emergence of amyloid PET scanning has really been, monumental in changing our ability to be more certain of a diagnosis of Alzheimer's disease. And CSF testing from lumbar puncture also extremely useful in this way. But I would say that it's still really important to point out that especially in the non-specialty setting, the precise role and ability to get insurance coverage for amyloid PET scanning is still fuzzy and complicated. And so now that we've got this blood-based biomarker for Alzheimer's disease, which is approved and is pretty accurate with some error, but it's important to say, what is it accurate at? It's accurate at predicting what somebody's amyloid PET scan will show. And that's really as I teach this to primary care providers, it's really keep focused on that is the value of the blood-based biomarker, is to predict what the amyloid PET scan will show. And then it's really worth kind of stepping back a second and saying, well, what exactly does that amyloid PET scan mean in the course of clinical care? Because there's still a lot that we don't know about the pathophysiology of Alzheimer's disease. We have a lot of clues, we have a lot of leads, we feel like we're making progress. We can identify these pathognomonic changes, but it's really important to keep in mind that a lot of healthy people with amyloid plaque in their brains go on to live long and happy lives and never develop dementia. And it's also important to identify that there are people who clinically really do seem to have Alzheimer's disease as the best fit for their impairment. But the results, especially of their blood-based biomarker, but even of their amyloid PET scan, may be still kind of equivocal. And so that as much as we feel like we have gotten better at the definition of what Alzheimer's disease is, there is still a fair amount of clinical uncertainty when you're kind of in the real world. But the central sort of core importance of all of this is that if amyloid is present in the brain, anti-amyloid drugs really have been shown to slow the progression of cognitive impairment by, at least a little bit. And so that I think that is really what has changed this field in a big way in thinking about what is a clinical utility of an amyloid PET scan, and then, adjacent to that is what is the clinical utility of a blood-based biomarker. And I was reading in the New York Times just this morning. This is, I think, came out 3 days ago. On the front page of the New York Times is this case of somebody who has genetic mutations that absolutely should have meant that he would develop early Alzheimer's disease, and he has huge amyloid burden in his brain, and yet that he is being very, very actively, carefully studied because he is not developing cognitive impairment. And so I think this is really front page news from 3 days ago that really does sort of really get to this very important concept that as much as we think we've got the amyloid hypothesis proved. It is still some degree of a hypothesis, and we are still early, but in an exciting place of, but we're still not completely there in feeling like we really understand Alzheimer's disease pathophysiology. But so let's think about some situations where blood-based biomarkers might be used. And so, here's a 78-year-old woman who has been diagnosed with mild cognitive impairment, and she expresses interest in learning more about anti-amyloid therapy. And so she is undergoing workup for eligibility for anti-amyloid therapy. And the question is her MCI due to Alzheimer's disease? And so, is there a role for blood-based biomarker in this setting? Absolutely yes. Like, so this is, the poster case for where blood-based biomarkers are changing practice. So much easier and less expensive to do a blood-based biomarker than an amyloid PET scan. And I think that Alzheimer's Association was very sort of careful and wise in their sort of talking about, is this blood-based biomarker a triaging test, meaning triaging of who needs a PET scan, or is it a sort of a diagnostic on its own test? And I think that there's still some fuzziness in there, but I think without any question, this is where blood-based biomarkers are revolutionary, important, and are practice changing in a big way. But now let's talk about another man who is 72 years old, who has a family history of dementia, and he is anxious because it sometimes takes longer for him to remember someone's name, but later it comes to him, and he's heard there is a blood test for Alzheimer's, and he's worried because he feels like he's at risk. And so the question is that a role for a blood-based biomarker? And, as Dr. Grabowski said, no, this is a terrible use for blood-based biomarkers as we currently understand them. And, this is a big risk of causing a lot of unnecessary confusion, anxiety, and possible harm when blood-based biomarkers would be used in a setting like this, where somebody does not have cognitive impairment, but is just sort of anxious about Alzheimer's disease. So what about a 75-year-old woman who presents to her PCP with general memory concerns, and you're starting your initial evaluation, and so you're going to order a TSH and a B12 as like really key important parts of that initial evaluation for a cognitive concern. And her daughter, who is with her, which is like really important to get that input from the observer and informant of how that person is doing, ask, isn't there also a blood test for Alzheimer's disease? And so the question there is, at this, very initial beginning of the workup point, is that a role for a blood-based biomarker? And I would also say no. And I think this is where there is going to be a lot of pressure and confusion in the primary care space of, should a blood-based biomarker be part of a sort of standard, initial evaluation, right up there with a TSH and a B12? Should you also order a blood-based biomarker in that setting? And I think, the guidelines for the Alzheimer's Association are clear, no. And I would agree with that, no, and I think that fits well with what Dr. Grabowski was just saying, is that these, as much as we would like them to be just like the quick, easy sort of hemoglobin A1C that's part of like an initial assessment of high blood sugar for diabetes, but I still would not say that we should be using blood-based biomarkers in a situation like that. So what about a more complicated situation? Like, say you've got a 71-year-old woman who is undergoing cognitive evaluation for memory concern, and she has an abnormally low MoCA score, but it's, not terribly low. It's kind of borderline. Her husband thinks that she's less organized than she used to be, but as often is the case when you kind of, push that family member, they hedge a little bit of like, I can't say for sure that this is a change. And so she's going to have a provisional diagnosis of, what maybe looks like mild cognitive impairment, but it's hard to know for sure. She takes apixaban, which is a very sort of potent blood thinner, so she would not be a candidate for an anti-amyloid drug, and she's not even sure that she would want an anti-amyloid drug even if she was eligible. And so that's a really sort of interesting question of like, what would be a role for a blood-based biomarker for her? And this could still be in a primary care setting. And I think this is the really interesting sort of scenario where I think we are still in a sort of gray area where it's a little bit hard to know, you know, could a blood-based biomarker potentially help in this clinical setting? Maybe. But I think that it's still early to say, and I think that I'm going to talk about that in a little bit more in my sort of summary sort of slide, which is, for sure, evaluating for anti-amyloid therapy off generally in the specialty setting, absolutely. What about new diagnosis of MCI or borderline findings where you're kind of unsure if somebody is going to progress to worsening cognitive impairment or not? Maybe. But what about initial workup before a diagnosis of a patient without impairment? Absolutely not. This is a terrible, I would almost say, contraindication to doing a blood-based biomarker. And so I think, bottom line is blood-based biomarkers are getting better at predicting when somebody will have amyloid PET evidence of plaque, but their clinical role is still pretty uncertain, especially in the primary care setting. And I really come back to the whole concept, and I can sort of say this as a primary care provider, how to interpret a blood-based biomarker result and talk to a patient and family about what exactly it means and doesn't mean is a really complex and psychologically hard and confusing thing, even for a specialist. I mean, I've sort of read between the lines of specialty notes where it's like there's a lot of hemming and hawing and uncertainty of like, what is the diagnosis and what does this mean and how should this like shape, talking about prognosis is really, really complicated and hard. And I would say that primary care is going to be really, really hard pressed to take this on in terms of how to interpret a blood-based biomarker result. And yet, but without question, there is clear, growing, important role for using blood-based biomarkers in the specialty setting, especially to streamline evaluation for whether anti-amyloid therapy might be indicated. But there is still very limited, if any, use for blood-based biomarkers by primary care providers at the present time. Could there be in the future? Yes, but really, I would really think that at least for the near term, this is really should be only after a diagnosis of mild cognitive impairment is made, and really only if there is quick access for patients to see a specialist soon if a biomarker is abnormal to help with that really complicated sort of counseling as to what does this blood-based biomarker mean. And so that's the end of my presentation, and I'm glad to see we have some time for discussion because this is a complicated and hard issue that is not easy.
Thank you, Brock. And thanks again, Tom. And if you want to stop thank you, great. And we can, I imagine that there are a number of questions from the community. So feel free to either put them in the chat or unmute yourself and pose a question.
And while we're waiting, I'll say a little bit more about you know, the very, very interesting conversations I've had with lots and lots of people from many different sort of fields and walks of life on this issue over the last, especially like 4 months, 3 months, which is that, I think that there's a danger to being too optimistic about the role of blood-based biomarkers, but I think there's also danger to being too pessimistic about them as well. I think that that we can get ourselves into trouble by putting more certainty into what a blood-based biomarker means than probably exists. But I also think that it's wrong to completely sort of discount how much the emergence of blood-based biomarkers can really be sort of practice changing in terms of understanding, understanding cognitive impairment better. I think that that the days of thinking of this being this kind of unknowable black box as to sort of what the cause of somebody's cognitive impairment was, and does it make how much of a difference does it make to understand it? I think we are moving into a place where, especially with the emergence of more types of blood-based biomarkers, will, I think, get us to a place where, even in the primary care setting, we're probably going to want to sort of embrace the ability to understand in a better pathophysiologic way what might be happening in somebody's brain.
Thank you. Yeah, and just underscoring, in the right clinical context, as both of you have emphasized, with objective clinical findings for either mild cognitive impairment or dementia, and not in the setting where somebody has subjective cognitive concerns. So really just underscoring that. Thanks, Brock. Julie?
Yeah, thank you. That was somewhat what I was going to ask about, is that concept of it would be wonderful to have more information than less information, that in an ideal world, it'd be wonderful to have the biomarkers and genetic testing with the cognitive evaluation, and maybe have it all seen in a more information would be better than not. So I imagine the current state is that the cost and the availability is one of the main limiting factors. But if it was such as like a CBC is so easy to run and have a result, and we know that it is open to gross interpretation of the reasons for certain results, then if it was more common, I think it'd be wonderful information to have more easily accessible to. On case number 2, where he was asking about a family history. Now, I've not had a patient ask me for genetic testing for Alzheimer's, but I've had many patients say, I've had a family history. Is the genetic testing fall in similar lines of like the biomarkers, of just the counseling is too difficult and too complex to really recommend?
Yeah, I would for sure. It's really important to make a very, very clear distinction between how different genetic testing is from blood biomarker testing for amyloid or tau, because the blood-based biomarker for amyloid and tau is really an attempt to understand what's happening in somebody's brain right now, whereas a genetic test is this like very, very fuzzy ball as to what may happen in their brain in the future, which is, that's like sort of like night and day, and so I really would caution against any of this conversation of blood-based biomarker to extend to talk about genetic testing, because genetic testing is like even a whole order of magnitude more uncertainty in terms of like what do you do with that result, and what effect should that have on somebody's clinical care. And so,
Oh,
so as much as I am, excited and eager about the possibility of blood-based biomarkers to really be practice changing in at least some parts of clinical care, I still am not seeing that for genetic testing, because I think how to interpret genetic tests into patients, and how to think about how to counsel anybody about what that should mean in terms of their clinical care is much, much less. It's much less clear than the blood-based biomarker.
much less clear. But I imagine there are other diagnoses where people want to know if they were genetically predisposed, so there are other family members. But for dementia, that is just too uncertain. It's not even on the table. Okay.
Yes.
I mean, I really agree with what Barak said, and even in our specialty clinic, the ApoE genetic test, we don't use it for that purpose at all. The only time we really use it is at the end of the decision chain around anti-amyloid therapy, because it also predicts risk of complication of the treatment. Otherwise, it wouldn't even come into play clinically. So it's a risk factor. It's not destiny, and it's complicated to explain to people.
Thank you. And Owen asks, do you think at this point that blood-based biomarkers have replaced the need for LP for the diagnosis of Alzheimer's disease?
So let me try to take a stab at that. Well, the blood tests look like they're probably about as good as the spinal fluid test. They're being held to the same standard. So in that sense, probably yes. But there are other things that you can tell from spinal fluid, and we're now learning that there's a really good Lewy body disease test in spinal fluid. So I think, watch this space. I think that may evolve as well. But I would say, for the purposes of Alzheimer, biomarker is probably equivalent.
Thank you. Carla.
Oh, hi, thanks. I think my question is back to the conversation. I think that both of you talked a little bit about folks with a mixed dementia picture, which obviously we see, and as the older people get, more of that happens. And this is more, for those of you who don't know me, I'm a primary care doc and a geriatrician, so I'm doing this in both spaces. I'm at Kaiser and I'm doing some cognitive clinic there. I think the folks who have, severe microvascular disease evident on imaging, but also have some, either from their cognitive testing or some other clinical presentation that makes it look like a mixed picture. Many of those folks are interested in talking about biomarker testing, right? Because we always are sort of like, well, it could be mixed, right? Because it could, and it's complicated. And I've been trying to think about a use case for it. And the only one I can come up with is if they thought at that point that they would be interested in anti-amyloid treatment specifically, right? I'm just wondering if, when you're thinking about folks who seem to really look more like the mixed vascular and AD specifically, I mean, I think to your point, Dr. Grabowski, in terms of like Lewy body and CSF testing, like we may be able to find some other mixed things that we can sort out with more advanced testing and specialty settings. But I'm wondering if for somebody who has cognitive impairment or early dementia, who looks like they have and has risk factors to really be both Alzheimer's and vascular dementia, are there a subset of folks for that who would benefit from biomarker testing? And is it really just for anti-amyloid treatment?
Well, yeah, so we do wrestle with this, of course, as we evaluate people for anti-amyloid treatment, and any excessive amount of microvascular disease in the brain that's evident on imaging is something we look at, and for people who have a physique 3 or greater white matter burden, they're not going to be candidates for anti-amyloid therapy, and we don't have a great way of knowing what's causing the microvascular troubles, and we worry that some of it's amyloid angiopathy, and that's a risk factor for complications. So if there's, I think as a general rule, if there's something that looks like may also be a major contributor to cognitive impairment other than Alzheimer's disease, we're cautious about anti-amyloid therapy, even if there's a positive test for Alzheimer's. And there's some absolute cutoffs as for severe or moderately severe white matter disease.
Yeah, I mean, the way that I really struggle with this for primary care a lot is, like the use case without question is determining, potential efficacy of anti-amyloid therapy. No question whatsoever, that's solid. But I do hold open, that was like the question mark, on the slide that I showed of the case that I showed, where we've all struggled mightily with that situation where you have diagnosed somebody with mild cognitive impairment, and whether or not anti-amyloid therapy is an option or going to be considered, there is still like that sort of unsettling sort of question of like, what is somebody's prognosis with mild cognitive impairment? And, because we all know that a fair number of people with mild cognitive impairment do not progress to dementia, that they can live for, a long, long, long time, and their MoCA score doesn't change, or it might even get better. And that is that's a we deal with lots of uncertainty in medicine, and especially deal with a lot of uncertainty in primary care, where I can't really tell you exactly sort of like what the future holds. But it still is a pretty unsettling sort of message to give, that you often will be sort of like met with these kind of like sort of like kind of questioning stares of like, really? Like you really can't tell me sort of like what's going to happen to me in the future. And so I mean, I think that the possibility that blood-based biomarkers could help to sort of provide more information to somebody newly diagnosed with mild cognitive impairment is worth at least sort of considering. And I mean, and so I don't think we're there yet. And I do feel like I'm worried about how complicated that interpretation is going to be. But I do think it's important to not be sort of at least excited about the possibility that blood-based biomarkers could play a role in helping to establish what somebody's prognosis is after a diagnosis of mild cognitive impairment. That they could, so just because their blood-based biomarker for amyloid doesn't necessarily show that they have Alzheimer's. It could mean that they have frontotemporal disease, or they have Lewy body disease. So it doesn't necessarily mean that their mild cognitive impairment is of a type that is less likely to progress. But I think if their blood-based biomarker shows evidence of amyloid pathology, then that is, not great news to give to somebody with mild cognitive impairment, but it is news. I mean, it is more information as to sort of what could be sort of going on in their brain, that I think it's fraught and complicated and a little bit scary to figure out how to navigate through it. But just because it's like strong, complicated and hard and scary doesn't mean that we should sort of dismiss it as a potential sort of future use of this testing. And I think that this is just still such early years and such an early time, and really trying to figure out how to use testing like this. I think the thing that I really kind of come back to is that one of my kind of key teaching points is how, even for a specialist, how to communicate this result to patients is really, really, really hard. And so it's like, if you can imagine how hard it is for a specialist to do that, it is 10 times as hard or 100 times as hard for a primary care provider to do it, since it's not what they're sort of used to doing sort of day in and day out. And so that's where I really come down, because I've had a lot of people around the country, present workflows where blood-based biomarkers are used in primary care as a triaging sort of test to sort of help you to identify people who should be sort of fast-tracked into to getting into a neurology clinic. And I am sort of open to that possibility, but I also really sort of call out the problem with it, which is that if it's going to take 9 months to get in to see the neurologist after that blood-based biomarker result, then I do not want to order that test in primary care and be on the hook for having to explain it, interpret it to that patient and family member sort of for the 9 months while they're waiting to get into somebody with more expertise to interpret that result. And so for me, I think whether there is going to be a role for doing blood-based biomarker testing in primary care, I really would like almost predicate it with a comfort concept that if the test is abnormal, that somebody's going to be able to get in to see a specialist quick. And when I say quick, I mean within 3 to 4 weeks, because people shouldn't be sort of left with this, potentially kind of like devastating news, and not have an expert to guide them to interpret the result. And, I think the light bulb moment that I had recently in talking to people in Toronto at the AIC meeting was trying to figure out what are analogous situations in other situations like primary care, where we might order a very complicated to interpret test to help the specialist. And I think the most sort of obvious analogy is when you have identified somebody who may have a myeloproliferative disease, something that could be sort of leukemia. You are often in primary care asked by the hematologist oncologist to order flow cytometry, to help to determine in a more sort of specific way what is the potential cause of somebody's sort of myeloproliferative disorder. And you're ordering that not because you, the primary care provider, are going to then be stuck interpreting that flow cytometry to the patient, but because the specialist has asked you to do it, and they're going to be able to see the patient in 2 to 3 weeks. But it's going to help them it's going to help that first visit with the hematologist, oncologist, to have that flow cytometry result in hand at that first visit. And so, I think that's like just a really, really good analogy, where if we can imagine a world where a specialist is going to be able to see that patient in 3 weeks after a blood-based biomarker result, that makes sense to potentially think about doing it in primary care.
Thank you. Thanks, Barack. And Tom, do you want to comment? Do you have anything you want to add?
I think that's a really outstanding point. I'm listening and learning. I wanted to go back to something a little bit ago when Barack said we don't really, like, people can live with MCI for a while, right? I think one thing that has been underemphasized is the importance of the complaint, okay, in the setting. So for people who have MCI who jump through whatever hoops they need to do to get into my clinic, MCI behaves one way, okay? Somebody with a positive marker in MCI is going to progress in that setting. In primary care, it might, there might be a really salient complaint, or there might be a sort of like one among other complaints, right? And it might the degree of concern, is an important prior in all this. And I think it's, establish the complaint, establish MCI, and if you need to, get some standardized cognitive testing for that. But nail down, is it really MCI or not? So that's what can be really helpful before they come to see us, to really understand what is the status.
Yeah, thanks. And I'll just piggyback on that to add, and I know, Brock, that you've spoken to this, and we have talked about this on many, many echo sessions, but thinking about more broadly, are there other factors that are contributing to the cognitive challenges, such as polypharmacy, such as untreated sleep apnea, such as hearing loss, and so forth? Things that we've talked about on many, such as this micronutrient deficiency or poorly managed diabetes. And so really looking holistically at these other modifiable contributing factors as well to get the full picture. Kelly?
Yes, no, thank you. This is a wonderful talk. I think I just want to make that one point that yes, the ATM profile is really helpful for screening patients, but it really isn't catching your patients with Lewy body or your frontal temporal disorders. And so, if you're just doing it for Alzheimer's, it can be helpful in ruling in or out Alzheimer's, but it's certainly not addressing the other cognitive, the other things that could be causing your patient to have cognitive complaints. And so to take a negative test as being like super reassuring and being like, oh, you're fine, get out of my office. You can't, you have to take a negative result as still not the full clinical picture. So
Yeah, good point.
Good point. Yeah. Thank you, Kelly. Important point.
Yeah, and I guess,
And
so
as
I
we
mean,
saw, pardon me, go on.
in that kind of scenario that I was describing of like, that, very uncomfortable situation of after a diagnosis of MCI and like, what does this mean? And what can we expect? That, whether or not a blood-based biomarker could be helpful in that situation to just help with the diagnosis and prognosis, is really, like you just said, Kelly, so important to emphasize that a positive blood-based biomarker is helpful because it probably is quite predictive of progression, and I think that there was a paper in JAMA maybe 9 months ago, using amyloid PET scanning in terms of prognosis over the course of the next 3 to 5 years. And the amyloid PET scan was very, very predictive of progression. And so you can get like the important but bad news if the blood-based biomarker is abnormal. But if somebody's blood-based biomarker is not abnormal for amyloid tau pathology, it's not that reassuring because it doesn't mean that lots of people who have a normal blood-based biomarker for amyloid tau pathology do get worse. They do progress, and they do develop dementia. And whether it's because of another cause or because we don't, it's a false negative for amyloid pathology for Alzheimer's. We don't know, and so I think it could potentially be a useful test to give bad news, but is not necessarily, it should definitely not be sort of viewed as a test that can give reassuring good news, if it is normal.
Great. Any other questions or comments from our community? It's been a great discussion.
And I would just like it, the emergence of an FDA-approved blood-based biomarker for Alzheimer's disease is like important and good, but I think if anything, it just like drives home the point like more than ever as just like this this like screaming desperate need that we have to improve the ability to diagnose mild cognitive impairment in primary care. I think that because these blood-based biomarkers are a terrible idea without a diagnosis of mild cognitive impairment, if we want to imagine a better world where blood-based markers are going to be really important and useful to getting people into sort of better care for Alzheimer's disease, that is all still completely predicated on the ability to detect and identify and diagnose mild cognitive impairment in the primary care setting.
To accurately detect.
Accurately detect.
Yes,
absolutely.
Indeed. To accurately detect in a timely manner. Yeah, very critical. Thank you. Kathy, did you have a comment? You raised your hand
I
and
did.
then.
Yeah, I
Okay.
did. I didn't want to interrupt
Yes.
Brock. First of all, I just want to say thank you for the discussion today. I love hearing all of the clinicians across the state have really robust conversations around this topic. Obviously, this has been highly relevant for us since our Toronto conference in July. And I just really appreciate the dialogue and that even just really kind of analyzing it, like, where does this fit? And just from a clinical standpoint, it's just very helpful for me as a layperson to hear the dialogue and understand just really where your comfort is around this as practitioners. So I just want to say thank you for including me in the discussion and letting me listen.
Thanks a lot. Thank you so much. All right. So we are nearly at time. And so just a reminder, please, thanks again, both Dr. Tom Grabowski and Brock Gaster for your awesome presentations and the community at large for a lively and informative discussion. I think there were so many learnings from this topic talk today on blood-based biomarkers. And upcoming cases, bring your cases forward, please, please, please reach out to Sarah. And we can help you also if you need some help in preparing the case. Reminder regarding CME. For UW faculty staff, just text this 13461 to the number, and otherwise it's tracked through our program coordinator and also through the analytics through Echo. And next time's didactic is Diagnosing Dementias, the age-old debate of phenotype versus pathology by Dr. Kelly Ramirez on the 24th of October, as I said. And please, again, do complete your 1-minute post-session survey, which, as you see, has been thrown in the chat by Sarah. And with 2 minutes to go, any last comments from anyone before we sign off? The gift of time.
I was just really pleasantly surprised how much agreement Brock and I have about this. This was not rehearsed.
Well aligned. Yes.
Yeah.
Consensus emerged for sure. Yeah.
Right. To me, it was really helpful and useful because, right, I mean, Dr. Grabowski and I sort of prepared our slides completely independently without talking to one another at all. And so I was a little sort of anxious about, like, gee, I hope we don't sort of massively disagree. And so I think it's really helpful and useful to have your sort of independent take on this, Tom, and see that we are quite a bit in alignment.
Great. So thanks, everyone, and see you in a couple of weeks.
Thank you, everyone.